You have just received a report on 4 patients. In what order will you assess them? Patient A 45-year-old post-op day 1 bowel resection complaining of incisional pain rated 7 out of 10. Patient B, an 80-year-old with pneumonia whose oxygen saturation dropped from 94% to 89% on a 2-liter nasal cannula during the previous shift. Patient C, a 68-year-old diabetic whose fasting blood glucose is 74 milligrams per deciliter, 4.1 millimoles per liter, and needs their morning meal tray. Patient D, a 72-year-old receiving an 4 antibiotic whose infusion pump is persistently alarming occlusion.
I will prioritize and assess these 4 patients in the following order: Patient B, Patient C, Patient A, and then Patient D. 1. Patient B, first priority. My absolute priority is Patient B, the 80-year-old with pneumonia whose oxygen saturation dropped to 89%. Under the standard ABC, airway, breathing, circulation, framework, this patient is experiencing acute respiratory insufficiency and hypoxemia. Geriatric patients have diminished physiological reserve and can decompensate rapidly into respiratory failure. I need to immediately assess their work of breathing, lung sounds, and mental status, increase their supplemental oxygen as permitted, and notify the medical team. 2. Patient C, second priority. I will assess Patient C next. While a blood glucose level of 74 mg per deciliter is technically within a normal fasting range, it sits right at the lower threshold. Because this patient is a diabetic who has been fasting, their blood sugar will drop rapidly if their morning meal or insulin is mismanaged. Delays can trigger severe, symptomatic hypoglycemia, a dangerous mimic of stroke or cardiovascular events in older adults. I will check on them, verify they are asymptomatic, and ensure their breakfast tray is delivered immediately. 3. Patient A, third priority. I will then see Patient A, the post-operative bowel resection patient. A pain score of 7 out of 10 is severe and requires timely intervention, but because the pain is localized to the surgical incision on post-op day 1, it is an expected clinical finding and not an immediate threat to life. Once Patient B's breathing and Patient C's metabolic status are secure, I will assess Patient A's surgical site for any complications like dehiscence, check their vital signs, and administer the prescribed analgesic. 4. Patient D, fourth priority. Finally, I will attend to Patient D. An alarming infusion pump indicates a mechanical issue rather than an immediate physiological crisis. While interrupting an antibiotic delay is important for maintaining therapeutic blood levels, troubleshooting equipment takes a back seat to treating active hypoxia, preventing a hypoglycemic crash, and managing severe pain. I will check the line for a kinked tube or a clamped port, flush the foresight to verify patency, and restart the infusion.
You need to call an on-call physician at 2 a.m. regarding a patient who has developed new-onset rapid atrial fibrillation with a heart rate of 140 bpm. Structure your report using the SBAR format.
When calling an on-call physician at 2 a.m., communications must be exceptionally crisp and structured to ensure rapid clinical decision-making. Here is the SBAR report tailored for this cardiac emergency. Dr. Evans, this is Nurse Smith on the Med-Surg unit. I am calling regarding Mr. John Doe in room 412, who has just developed new-onset, rapid atrial fibrillation with a heart rate fluctuating between 140 and 145 beats per minute. Mr. Doe is a 74-year-old patient admitted yesterday for a right total knee arthroplasty. He has a history of hypertension and controlled type 2 diabetes, but no known history of arrhythmias. Up until an hour ago, his vital signs were stable, and his baseline cardiac rhythm was normal sinus bradycardia at around 62 beats per minute. I assessed the patient 10 minutes ago when his telemetry alarm sounded. He is currently awake and alert but reports feeling sudden chest palpitations and mild shortness of breath. His blood pressure is holding stable at 118/74 mmHg, his oxygen saturation is 95% on room air, and he is afebrile at 36.8 degrees Celsius. I have already performed an immediate 12-lead ECG, which confirms acute atrial fibrillation with a rapid ventricular response and no ST segment elevations. Because he is currently hemodynamically stable but symptomatic, I recommend initiating rate control therapy. Would you like me to administer an intravenous bolus of diltiazem or metoprolol, or should I establish a continuous infusion? I also recommend ordering an urgent stat serum electrolyte panel and a portable chest X-ray. I will keep the patient on continuous telemetry and hold him strictly nil by mouth in case an urgent cardioversion becomes necessary. Can you come to the unit to evaluate him?
An isolated elderly patient with poorly controlled type 2 diabetes and a healing foot ulcer is being discharged home. What multidisciplinary resources will you advocate for to ensure they do not readmit within 30 days?
To ensure this isolated elderly patient transitions safely to the home environment and avoids a 30-day hospital readmission, I will advocate for a comprehensive, multidisciplinary care network before discharge. This strategy addresses their medical, physical, social, and nutritional needs simultaneously. 1. Community nursing services. I will advocate for immediate referral to a community health nursing team for scheduled home visits. A community nurse will provide essential continuity of care by performing regular, sterile wound assessments and dressing changes for the healing foot ulcer. Crucially, they will monitor the patient's daily blood glucose trends, assess their ability to self-administer insulin or oral medications, and perform targeted physical assessments to catch early signs of localized infection or worsening tissue breakdown before it escalates. 2. Specialized podiatry and wound care clinic. I will arrange priority outpatient appointments with a dedicated podiatry or wound care specialist. Managing a diabetic foot ulcer requires advanced, regular maintenance, including professional debridement if necessary and specialized pressure offloading adjustments. Ensuring the patient has a clear, scheduled pathway to see a podiatrist prevents the wound from stagnating and addresses structural foot issues that could trigger secondary ulcers. 3. Medical social work and case management. Given the patient's isolated status, a social work referral is vital to evaluate and reinforce their social determinants of health. The social worker will assess the home environment for safety and fall hazards, arrange for assistive devices, and coordinate community-based resources. They can organize a local volunteer network or professional home health aides to assist with daily living activities, ensuring the patient is not left completely unmonitored. 4. Dietitian and Certified Diabetes Educator, CDE. I will secure home health or outpatient referrals to a registered dietitian and a diabetes educator. Tight glycemic control is non-negotiable for wound healing, yet an isolated older adult often struggles with meal preparation and complex dietary guidelines. The dietitian will establish a realistic, high-protein meal plan that fits their budget and mobility constraints to promote tissue repair. Simultaneously, the diabetes educator will simplify their medication regimen, use teach-back methods to confirm safe administration, and provide clear guidelines on when to seek urgent medical help.
A geriatric patient with end-stage renal failure is transitioned to palliative comfort care. The family is highly distressed because the patient's breathing has become loud and rattling, commonly called a death rattle. How do you compassionately explain this to the family, and what nursing interventions can provide comfort?
During my time working in a specialized palliative unit, an 80-year-old patient with end-stage renal failure entered the active dying phase. Within an hour, the patient developed terminal secretions, creating a loud rattling sound that caused severe distress to the 3 family members at the bedside. My immediate responsibility was to alleviate the family's intense anxiety while maximizing the patient's physical comfort during their final hours. I pulled up chairs so we were all at eye level and gently explained that this sound was a natural part of the body slowing down. I reassured them that because their loved one was in a deep, peaceful sleep, they were not choking or in any pain. To physically address the fluid buildup without causing trauma, I immediately avoided deep mechanical suctioning, which would have triggered a painful gag reflex. Instead, I carefully repositioned the patient onto their left side to let gravity drain the secretions naturally. I also administered a prescribed subcutaneous dose of glycopyrronium bromide to dry up further fluid production. Within 30 minutes, the rattling sound decreased significantly, and the family visibly relaxed, spending the remaining 2 hours holding the patient's hand in a quiet, dignified environment.
You are preparing a patient for an urgent surgical procedure. When you ask the patient if they have any questions, they state, "The doctor didn't really explain why I need the surgery, but I signed the paper anyway." What is your legal and ethical responsibility as their nurse in this scenario?
In a busy emergency department, a 60-year-old patient was fast-tracked for an urgent laparotomy due to a suspected bowel perforation. While completing the preoperative checklist, the patient admitted they signed the consent form without understanding why the surgery was necessary. My legal and ethical duty as a registered nurse explicitly prevents me from sending a patient to theater without truly informed consent. Even though a signed paper existed, the patient lacked basic comprehension, making the consent invalid. I immediately halted the pre-op transit, marked the chart as pending, and contacted the attending surgical registrar. While waiting, I sat with the patient and their spouse to explore their specific fears, discovering that a severe language barrier had caused the breakdown in communication. I secured an official hospital interpreter within 10 minutes and advocated for the surgical team to return to the bedside. I facilitated a three-way conversation where the surgeon re-explained the procedure, the risks of refusal, and the expected recovery timeline. Once the patient verified full understanding via the interpreter, they willingly reconfirmed consent. This 10-minute delay protected patient autonomy, fulfilled my legal obligations, and ensured the surgery proceeded safely and ethically.
You're caring for an 82-year-old patient who is 12 hours post-op from a hip arthroplasty. Their oxygen saturation suddenly drops from 96% to 88% on room air. Walk me through your immediate, sequential nursing actions.
An 82-year-old patient experiencing acute hypoxia 12 hours after a hip arthroplasty requires urgent, systematic intervention. I would immediately sit the patient up into a high Fowler's position to maximize lung expansion, keeping the fresh hip incision secure and supported. Next, I would apply high-flow oxygen via a non-rebreather mask at 15 liters per minute to rapidly correct the desaturation. While doing this, I would check the airway for obstruction and conduct a focused respiratory assessment, noting breath sounds, breathing effort, and chest symmetry. Simultaneously, I would verify the pulse oximeter probe placement on a warm finger to ensure the reading is accurate. I would then check vital signs and quickly scan the surgical site and calf area for any bleeding or signs of deep vein thrombosis. Given the high risk of a pulmonary embolism or atelectasis in orthopedic patients, I would immediately escalate the situation to the medical team or call the rapid response team. While awaiting their arrival, I would prepare for an arterial blood gas draw, an emergency chest X-ray, and an ECG. I will remain at the bedside to provide calm reassurance to the patient and monitor their neurological status.
A METAS-URG patient with a known urinary tract infection, UTI, becomes progressively lethargic. Their blood pressure drops to 90/50ths millimeter of mercury, heart rate rises to 112 bpm, and core temperature is 38.9 degrees Celsius, 102 degrees Fahrenheit. What is your immediate clinical suspicion, and what interventions do you anticipate?
My immediate clinical suspicion is urosepsis, a life-threatening systemic infection originating from the urinary tract that is now progressing into septic shock. The patient's altered mental status, severe hypotension, tachycardia, and high fever perfectly meet the criteria for a medical emergency. I would immediately activate the hospital's rapid response protocol to bring advanced medical support to the bedside. I anticipate implementing the standard sepsis hour, one bundle right away. My first physical action would be establishing 2 large-bore intravenous lines to rapidly infuse a prescribed crystalloid fluid bolus at 30 ml per kilogram to restore blood pressure. I will draw a serum lactate level and 2 sets of blood cultures from separate sites, alongside a fresh urine sample for culture. Immediately after collecting these cultures to identify the pathogen, I will administer the ordered broad-spectrum intravenous antibiotics without delay. To monitor fluid balance and organ perfusion accurately, I will insert an indwelling urinary catheter to track hourly urine output, aiming for at least 0.5 ml per kilogram per hour. Finally, I will check the blood glucose level and continually monitor vital signs every 15 minutes, preparing to anticipate vasopressor therapy if the blood pressure fails to respond to the initial fluid resuscitation.
You find a diabetic geriatric patient confused, sweating, and slurring their words. How do you quickly differentiate between a hypoglycemic event and an acute ischemic stroke at the bedside?
To differentiate rapidly at the bedside, my very first and most definitive action is to check a point-of-care fingerstick blood glucose level. Hypoglycemia is a notorious stroke mimic, because neuroglycopenia, a shortage of glucose in the brain, can cause focal neurological deficits like slurred speech alongside global confusion and sweating. If the reading is below 70 mg per deciliter, I will immediately treat it as severe hypoglycemia by administering intravenous dextrose or oral glucose gel per protocol. Simultaneously, I will perform a rapid BFAST neurological assessment to check for classic stroke indicators. I will look for sudden balance loss, visual changes, facial drooping, one-sided arm weakness, and speech difficulties. While hypoglycemia usually causes systemic autonomic symptoms like diaphoresis and tachycardia, an acute ischemic stroke typically presents with highly localized, asymmetric neurological deficits without the cold sweat. If the blood glucose level returns to normal but the patient exhibits sudden, one-sided weakness or facial asymmetry, I will immediately call a stroke alert to activate the emergency neurology team. Even if the glucose level is low and treated, I will closely reassess the patient within 15 minutes. A lack of rapid neurological improvement after blood sugar correction strongly suggests a concurrent acute stroke.
A patient with a history of congestive heart failure, CHF, is receiving 4 fluids for dehydration. They suddenly complain of severe shortness of breath and a cough producing pink, frothy sputum. What is your immediate nursing priority?
My immediate clinical suspicion is acute pulmonary edema triggered by fluid overload, which is a major risk for patients with congestive heart failure. The classic sign of pink, frothy sputum confirms that fluid is rapidly backing up from the failing left ventricle into the alveoli, creating a critical gas exchange emergency. My very first action is to completely stop the intravenous fluid infusion to prevent further fluid volume overload. I will instantly sit the patient completely upright in a high Fowler's position with their legs dangling over the side of the bed. This positioning is vital because it leverages gravity to pool blood in the lower extremities, which decreases venous return and reduces the workload on the heart. I will immediately initiate high-flow supplemental oxygen therapy via a non-rebreather mask to address the acute hypoxia, or prepare for non-invasive positive pressure ventilation if they continue to struggle. While calling for the rapid response team and notifying the physician, I will perform a focused chest assessment to check for bilateral crackles. I anticipate the urgent administration of intravenous loop diuretics like furosemide to clear the fluid, alongside nitrates to reduce cardiac preload. I will continuously monitor their oxygen saturation, blood pressure, and heart rate, while keeping a close eye on their emotional state to provide calm reassurance during this distressing episode.
A patient admitted for an exacerbation of peptic ulcer disease suddenly vomits 300 milliliters of coffee ground emesis. What assessments do you perform immediately, and how do you prepare for potential hypovolemic shock?
The coffee ground emesis confirms an active upper gastrointestinal bleed where blood has reacted with stomach acid. My immediate nursing priority is to assess the patient's hemodynamic stability and prepare for a rapid volume depletion emergency. I will immediately check the patient's vital signs, focusing on low blood pressure and a high heart rate, which are the earliest indicators of moving into hypovolemic shock. I will perform a quick neurological assessment to evaluate brain perfusion, checking if the patient has become dizzy, confused, or lethargic. Next, I will assess their physical appearance for pale, cold, or clammy skin, which indicates the body is shunting blood to vital organs. I will inspect the abdomen for distension, rigidity, or severe tenderness, and immediately review their current medication history for blood thinners or NSAIDs. To prepare for potential hypovolemic shock, I will quickly establish 2 large-bore intravenous lines, preferably using 16-gauge or 18-gauge catheters. I will draw blood samples immediately for an urgent type and cross-match, a complete blood count to check hemoglobin, and coagulation profiles. I will start a rapid infusion of normal saline or lactated Ringer's solution as ordered to maintain blood pressure, while keeping the patient strictly nil by mouth. I will insert an indwelling urinary catheter to monitor kidney perfusion through hourly urine output. Finally, I will notify the physician and the emergency endoscopy team, keeping blood transfusion supplies and oxygen delivery equipment ready at the bedside.
An 85-year-old patient with mild baseline dementia undergoes an emergency gallbladder removal. On post-op day 2, they suddenly become highly agitated, hallucinating, and pulling at their foreline. How do you distinguish between their baseline dementia and hyperactive delirium?
To distinguish between baseline dementia and hyperactive delirium, my immediate priority is to assess the timeline and the nature of the patient's symptoms. Dementia is a chronic, progressive condition characterized by a gradual decline in memory and cognitive function over months or years. In contrast, delirium is an acute medical emergency featuring a sudden change in mental status that develops over hours or days, characterized by a fluctuating course throughout the day. I will immediately perform the confusion assessment method, CAM, at the bedside, which is the international standard for identifying delirium. While a patient with baseline dementia may be disoriented, a patient experiencing hyperactive delirium will show a profound, acute disturbance in attention, making them completely unable to focus or follow simple commands. They will also exhibit a disorganized thinking pattern, altered levels of consciousness, and sudden perceptual disturbances like visual hallucinations, which are not typical for mild dementia. To confirm this shift, I will urgently interview the family or review the nursing notes from the previous shift to establish the patient's true baseline. This allows me to verify that the extreme agitation, hallucinations, and line pulling represent an abrupt, severe deviation from their normal cognitive state. I will then perform a physical assessment to look for the underlying physiological triggers of postoperative delirium, such as acute pain, hypoxia, an underlying infection like a UTI, or medication side effects.
Older adults rarely present with textbook symptoms. How might an acute heart attack or an acute abdominal perforation present differently in a 90-year-old patient compared to a younger adult?
In a 90-year-old patient, an acute heart attack frequently presents without any crushing chest pain. Instead of the classic symptoms seen in younger adults, a geriatric patient experiencing a myocardial infarction is far more likely to present with sudden, unexplained confusion, profound weakness, or an abrupt onset of breathlessness. This atypical presentation occurs because aging nerves alter pain perception, and the heart's changing dynamics can manifest directly as acute heart failure or global brain hypoperfusion rather than localized chest distress. Similarly, an acute abdominal perforation in a 90-year-old rarely produces the textbook rigid, board-like abdomen, high fever, or agonizing, localized pain typically seen in younger individuals. Due to weakened abdominal musculature and a blunted immune response, an elderly patient might only complain of mild, vague discomfort or general nausea. Instead of classic peritonitis signs, their primary presentation often manifests as a sudden change in mental status, a rapid decline into hypovolemic or septic shock, or unexpected hypothermia. Because these life-threatening conditions present so subtly, nurses must maintain a very high index of suspicion, looking beyond traditional symptoms to catch subtle changes in vital signs or baseline behavior.
You are reviewing an elderly admissions home medication list, which includes a benzodiazepine, a loop diuretic, and an antihypertensive. What specific nursing diagnoses and preventative interventions will you initiate based on this profile?
This specific medication profile creates an exceptionally high risk for adverse clinical events in an elderly patient. My primary nursing diagnosis is risk for falls related to the combined side effects of central nervous system depression, volume depletion, and orthostatic hypotension. The benzodiazepine causes sedation and gait instability, while the loop diuretic and antihypertensive work together to rapidly lower blood pressure, especially upon standing. To mitigate this risk, I will immediately initiate a comprehensive, high-risk fall protocol. I will place a high-risk fall visual indicator over the bed, ensure the call bell is always within reach, and keep the bed in its lowest position with the wheels locked. I will explicitly instruct the patient to implement the dangle technique, sitting on the edge of the bed for 2 full minutes before attempting to stand, to allow their blood pressure to stabilize. I will also coordinate scheduled toileting assistance, particularly during the peak action hours of the loop diuretic, to prevent unassisted, rushed trips to the bathroom. My secondary nursing diagnosis is risk for fluid and electrolyte imbalance related to excessive diuretic therapy. Loop diuretics aggressively flush out fluids, potassium, and sodium. I will closely monitor the patient's daily weights and track strict intake and output fluid balances. I will check for physical signs of dehydration, such as dry mucous membranes or poor skin turgor, and perform regular orthostatic vital sign checks to assess for a drop in blood pressure upon standing. Finally, I will advocate for regular serum electrolyte panels to closely monitor for hypokalemia, low potassium, which can trigger severe cardiac arrhythmias in an older adult.
Describe your comprehensive strategy for preventing pressure ulcers in an immobile, incontinent geriatric patient who is severely malnourished with very low serum albumin levels.
This patient presents a critical triad of risk factors. Immobility causes prolonged mechanical pressure, incontinence introduces moisture and chemical irritation, and severe malnutrition with low albumin compromises cellular integrity and causes tissue edema. My strategy targets all 3 areas to prevent rapid tissue breakdown. To manage immobility, I will place the patient on an alternating pressure air mattress and implement a strict 2-hour turning schedule, utilizing a 30-degree lateral tilt to keep pressure off the sacrum and trochanters. I will use slide sheets during repositioning to eliminate friction and shearing forces. Heel protector boots will be applied to float the heels completely off the bed surface. To control moisture from incontinence, I will check the patient every 2 hours, cleansing the skin immediately after each episode with a pH-balanced, no-rinse cleanser. I will apply a thick layer of a zinc oxide-based moisture barrier cream to shield the perineum and sacrum from enzymatic breakdown, avoiding plastic-backed pads that trap heat. To address severe malnutrition, I will collaborate immediately with a dietitian to initiate a high-protein, high-calorie nutritional plan supplemented with zinc, vitamin C, and arginine to support tissue viability. Because low serum albumin shifts fluid into the tissues, I will handle the edematous skin with extreme gentleness during all transfers.
An elderly patient with a history of a previous stroke is admitted with aspiration pneumonia. What concrete nursing interventions will you implement during meals and medication administration to prevent further microaspiration?
An elderly patient with a history of stroke and aspiration pneumonia has a highly compromised swallow reflex, requiring strict clinical safeguards to prevent recurrent microaspiration. Before introducing any food or medication, I will ensure the patient is sitting fully upright at a 90-degree angle in bed or a chair, with their head slightly flexed forward in a chin-tuck position. This posture naturally closes the airway and widens the esophagus. I will visually inspect the oral cavity to ensure it is completely clear of secretions. During meals, I will strictly adhere to the speech therapist's recommendations, ensuring all liquids are thickened to the prescribed consistency and foods are mechanically altered. I will feed the patient slowly using a teaspoon, placing food on the unaffected side of the mouth, and verbally remind them to swallow twice per bite. I will constantly monitor for subtle signs of silent aspiration, such as watery eyes, throat clearing, or a wet, gurgling voice. For medication administration, I will never mix crushed pills into thin water. Instead, I will crush compatible medications and administer them in a thick medium like applesauce or yogurt, which passes safely down the esophagus. I will advocate for liquid alternatives or alternative routes if the patient struggles with large tablets. Finally, I will keep the patient upright at 90 degrees for at least 30 to 45 minutes after every meal and medication pass to prevent silent gastric reflux and subsequent aspiration.
A patient is transitionally started on a continuous 4-heparin infusion alongside oral warfarin for a deep vein thrombosis, DVT. What specific lab values are you tracking daily? What physical assessments are mandatory? And what is your immediate antidote protocol?
When managing a bridging protocol of continuous intravenous heparin and oral warfarin for a deep vein thrombosis, careful monitoring is critical. Warfarin takes several days to deplete existing clotting factors, which makes the fast-acting heparin necessary to provide immediate anticoagulation during this high-risk transition window. For daily laboratory tracking, I will monitor the activated partial thromboplastin time or anti-XA levels every 6 hours to adjust the heparin infusion pump according to the weight-based nomogram. I will simultaneously check the prothrombin time and international normalized ratio daily to track the gradual therapeutic onset of the warfarin. The heparin infusion will only be discontinued once the international normalized ratio remains stable within the target therapeutic range of 2.0 to 3.0 for at least 2 consecutive days. Additionally, I will monitor a daily complete blood count, paying close attention to hemoglobin, hematocrit, and platelet counts to watch for occult bleeding or a sudden drop in platelets that could signal heparin-induced thrombocytopenia. My mandatory physical assessments focus heavily on early hemorrhage detection. I will inspect the skin daily for bruising, petechiae, or bleeding around intravenous insertion sites, and closely monitor the neurological status for any changes that might suggest an intracranial bleed. I will check the urine and stool for hidden blood, examine the gums after oral care, and assess the affected lower extremity for a decrease in circumference, pain, or warmth to ensure the deep vein thrombosis is resolving. If a severe hemorrhage occurs, I will immediately stop all anticoagulant infusions and activate the emergency antidote protocol. For a heparin overdose, the immediate antidote is intravenous protamine sulfate, which is typically administered at a dose of 1 mg per 100 units of heparin given over the previous few hours. To reverse a life-threatening warfarin overdose, I will immediately administer intravenous vitamin K as ordered, alongside a rapid infusion of prothrombin complex concentrate to replace depleted clotting factors instantly.
You are administering 4-furosemide, Lasix, to a patient with fluid volume overload. Which specific electrolyte imbalance are you most concerned about? What are its clinical signs, and what safety checks must you perform before administering replacement therapy?
When administering intravenous furosemide, my primary clinical concern is the rapid development of hypokalemia, low potassium. Because furosemide is a potent loop diuretic, it actively blocks the reabsorption of sodium, chloride, and potassium in the thick ascending limb of the loop of Henle, causing excessive potassium excretion in the urine. The clinical signs of hypokalemia reflect a dangerous slowdown in excitable tissue activity. Neuromuscular symptoms manifest as profound muscle weakness, generalized fatigue, painful muscle cramps, particularly in the calves, and a sluggish bowel that can lead to a paralytic ileus. Most critically, severe hypokalemia alters cardiac conduction, presenting as a weak, irregular pulse, orthostatic hypotension, and dangerous arrhythmias. On an electrocardiogram, I would look closely for hallmark signs like flattened or inverted T waves, ST segment depression, and the appearance of prominent U waves. Before administering any potassium replacement therapy, I must perform several strict safety checks to prevent fatal cardiac arrest from accidental hyperkalemia. First, I will independently verify the patient's most recent serum potassium level to confirm the deficit and cross-check the ordered dose. Second, I will check the patient's renal function by evaluating their blood urea nitrogen, creatinine, and hourly urine output. If the patient is oliguric, producing less than 30 milliliters of urine per hour, I must hold the potassium and notify the provider, as failing kidneys cannot excrete potassium, leading to a rapid, toxic buildup. Furthermore, I will confirm that intravenous potassium is never given via intravenous push or bolus, as a rapid concentrated dose will cause immediate cardiac arrest. I will ensure the solution is properly diluted, verify that the continuous infusion rate does not exceed the standard 10 milliequivalents per hour through a peripheral line, and always use an electronic infusion pump. Finally, I will inspect the intravenous site frequently for signs of phlebitis or infiltration, as potassium is highly irritating to peripheral veins, and place the patient on a continuous cardiac monitor throughout the replacement to watch for any changes in rhythm.
15 minutes into a packed red blood cell transfusion, your patient develops lower back pain, chills, and a fever. Outline your immediate, exact steps according to standard safety protocols.
The patient is exhibiting the classic presentation of an acute hemolytic transfusion reaction, a life-threatening medical emergency typically caused by ABO blood group incompatibility. The lower back pain signifies rapid, intravascular destruction of the donor red blood cells by the patient's antibodies, which causes severe kidney inflammation and acute renal failure. My very first action is to completely stop the blood transfusion immediately. I will disconnect the entire blood administration tubing setup directly from the patient's intravenous catheter hub. I will then attach an entirely new, sterile intravenous administration line to the catheter and initiate a slow infusion of 0.9% normal saline to maintain open venous access and support kidney perfusion. It is critical that I do not simply flush the existing blood tubing, as doing so would inadvertently force the remaining incompatible blood into the patient's circulation. I will immediately call for assistance, perform a rapid physical assessment to verify vital signs, check airway patency, and provide supplemental oxygen if the patient displays respiratory distress. I will urgently notify the attending physician and the hospital blood bank about the reaction. Following standard hospital safety protocols, I will perform a meticulous clerical recheck at the bedside, verifying the patient's identification band against the blood product bag label and cross-match documents to look for any documentation errors. I will then collect fresh blood samples from the opposite arm and a fresh urine sample to send to the laboratory to check for hemoglobinuria, which confirms active red blood cell destruction. Finally, I will wrap the remaining blood bag, the entire attached administration tubing, and all identification tags securely in a biohazard bag and return them to the blood bank for a formal transfusion reaction investigation.
A 78-year-old opioid-naive patient is prescribed 4 morphine for severe postoperative pain. How do you balance adequate pain management with the heightened risk of respiratory depression and opioid-induced bowel immobility in this demographic?
In managing severe postoperative pain for a 78-year-old opioid-naive patient, my strategy focuses on tight clinical monitoring and a proactive, multimodal approach to minimize opioid side effects. Because an older brain and aging kidneys are highly sensitive to opioids, I will adopt the clinical standard of start low and go slow, utilizing the lowest effective dose of intravenous morphine while actively tracking its impact. To balance pain relief with the risk of respiratory depression, I will perform a baseline respiratory assessment before each dose and monitor the patient using the Passero opioid-induced sedation scale. Because sedation precedes respiratory depression, checking how easily the patient arouses is my most reliable early warning sign. I will monitor their respiratory rate, depth, and oxygen saturation closely, keeping the emergency antidote, intravenous naloxone, readily available at the bedside. To minimize the total morphine required, I will round-the-clock administer ordered non-opioid coanalgesics, such as paracetamol, which safely target pain through a different physiological pathway. To combat opioid-induced bowel immobility, I will not wait for constipation to develop. I will collaborate with the medical team to initiate a prophylactic bowel regimen, including a scheduled stool softener and a stimulant laxative, immediately alongside the first morphine dose. Furthermore, I will implement early, assisted mobilization, encouraging the patient to sit up or walk short distances within their physical limits to naturally stimulate gastrointestinal peristalsis. Finally, I will maintain an accurate intake and output log and perform regular abdominal assessments, checking for distension and active bowel sounds to ensure early detection of a potential paralytic ileus.
You are assigned a patient who is positive for vancomycin-resistant enterococcus, VRE, in a wound, and another who is positive for C. diff, Clostridioides difficile. Explain your strict barrier nursing and hand hygiene protocols for both.
To prevent the cross-contamination of vancomycin-resistant enterococcus, VRE, and Clostridioides difficile, C. diff, I will strictly enforce contact precautions for both patients, treating each room as an isolated containment zone. For the patient with a VRE-infected wound, my protocol focus is on containing shedding from the wound site. Before crossing the threshold of the room, I will perform hand hygiene using an alcohol-based hand rub and don a clean, non-sterile gown and gloves. I will utilize dedicated, patient-specific equipment, such as a single-use stethoscope and blood pressure cuff, that remains inside the room. During wound care, I will be meticulous in my technique to avoid touching surrounding surfaces with contaminated gloves. Upon leaving, I will doff my gown and gloves inside the room, discard them in a clinical waste bin, and immediately apply alcohol hand rub. For the patient with C. diff, the protocol changes critically regarding hand hygiene because C. diff forms highly resilient, alcohol-resistant spores. While the barrier gowning and gloving process before entering the room remains exactly the same, my exit routine is entirely different. Upon removing my PPE inside the C. diff room, I must never use alcohol gel. Instead, I will walk directly to the sink and wash my hands vigorously with antimicrobial soap and water for at least 20 seconds. The friction and running water are mechanically necessary to rinse the physical spores off my skin. Furthermore, I will ensure that the C. diff room is disinfected solely with a chlorine-based bleach solution, as standard quaternary ammonium disinfectants fail to kill C. diff spores, risking transmission to the wider ward environment.